Rheumatoid arthritis is a chronic disorder, means that symptoms last for a prolonged period of time, usually longer than 6 weeks. It's autoimmune disorder, and as any autoimmune disorder, rheumatoid arthritis more commonly affects females, and usually rheumatoid arthritis manifests in a young age. Autoimmune reactions provoke production of autoantibodies. In rheumatoid arthritis, it's anti-citrullinated protein antibody and immunoglobulin M against Fc portion of immunoglobulin G. We call this antibody rheumatoid factor. Autoimmune aggression causes severe inflammation, and severe inflammation causes very prolonged morning stiffness, usually greater than 1 hour. Because, as we know, the more severe is the inflammation, the more prolonged is the morning stiffness. So to explain these key features of rheumatoid arthritis, we have to know the pathogenesis. Inside the joint, we have multiple peptides. We use peptides for cartilage formation, for bone tissue production, and also we use them to maintain integrity of synovial membrane. Some portion of peptides undergo citrullinatation. Citrullination is a totally physiological process that is provided by peptidyl arginine deaminase. We call it PAD enzyme. Basically, PAD enzyme binds a citrulline residue to a peptide, and by this we produce citrullinated peptides. In the joint we have antigen-presenting cells, mostly it's macrophages. Antigen-presenting cells phagocyte some portion of citrullinated peptides, and then macrophages present citrullinated peptide on their MHC2 receptor to T helpers. One of the crucial functions of T helpers is to determine if the substance is antigen or not. T helpers income to MHC2 receptor, and then they scan citrullinated peptides to determine if citrullinated peptide is antigen or it's not antigen. Because if it's not antigen, then there is nothing wrong about it. And in healthy individual, T helpers do not see any danger in citrullinated peptides, and because of this, they do not react. But if only T helpers will recognize peptide as antigen, they will immediately trigger inflammatory response. So basically we can say that T helpers determine to start inflammatory response or not, and in normal individuals, T helpers do not recognize citrullinated peptides as antigens, and thereby they do not react to citrullinated peptides with inflammation. But if person has HLA-DRB1-01 and HLA-DRB1-04 alleles, most probably inflammation will develop. And to understand why, we have to know how antigen presentation occurs. In normal condition, when citrullinated peptide is produced, macrophage intakes citrullinated peptide in order to present this peptide to T helpers. And antigen presentation occurs by an MHC2 receptor. What we have to know about MHC2 receptor is that it's a protein, and the genetic information that tells how to make MHC2 receptor is contained in the gene that is located on chromosome 6, and we call this gene HLA-DRB1 gene. But we have different variations of HLA-DRB1 genes, and such variations we call alleles. The simplest analogy is the eye color. You see, we all have genes that encodes the color of our eyes, but some of us have blue eyes and some of us have black eyes. In this case, genes that encodes blue eyes we call blue allele, and genes that encodes black eyes we call black allele. So we all have genes that encodes eye color, but this gene can be different, and different variations which are blue and black colors of the same gene that in this case encodes eyes we call alleles. So in case of rheumatoid arthritis, we all have genes that encodes MHC2 receptor. We call this gene HLA-DRB1, but this gene can be different, and different variations of HLA-DRB1 gene we call HLA-DRB1 alleles. For example, if person has HLA-DRB1-03 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DRB103 allele, and such MHC2 receptor presents gliadin in a perfectly normal way. And when T helpers income to this receptor, they recognize citrullinated peptide as normal substance, and because of this, they do not see any danger. If person has HLA-DRB107 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DRB107 allele, and such MHC2 receptor presents citrullinated peptide also in a perfectly normal way, thereby there will be no inflammatory response. But some individuals have HLA-DRB101 allele, thereby in this case person will have MHC2 receptor that was made based on genetic information in HLA-DRB101 allele. The problem is that this particular MHC2 receptor do not know how to present citrullinated peptide to T helpers. When T helpers income to MHC2 receptor, in this case, because citrullinated peptide is presented in abnormal way, they cannot recognize citrullinated peptide, and thereby they think that it's antigen. And also, if person has HLA-DRB104 allele, MHC2 receptor that was made based on genetic information in HLA-DRB104 allele, also do not know how to present citrullinated peptide. And because citrullinated peptide is presented to T helpers in abnormal way, T helpers recognize citrullinated peptide as antigen. In response to any antigen, T helpers immediately becomes activated, and subsequently they activate B lymphocytes that begin to produce antibodies, and also they activate T killers. So in individuals that have HLA-DRB101 and 04 alleles, MHC2 receptor presents citrullinated peptide in abnormal way, and because of this, T helpers recognize citrullinated peptide as antigen. But it's not the only factor that cause immune break. Smoking, silica exposure, periodontitis, they all create inflammatory state in the organism. With inflammation, neutrophils come into the site of inflammation where they provide immune defense. Inside them, neutrophils have PAD enzyme. And as we know, in the site of inflammation, neutrophils begin to die. With neutrophils' death, PAD enzyme is released into the blood. With increasing concentration of PAD enzyme, citrulination of peptides increase. And as a result, organism begin to produce hypercitrullinated peptides that have a lot of citrulline residues. Then macrophages uptake hypercitrullinated peptides and present them to T helpers. The problem is that T helpers cannot recognize peptides in hypercitrullinated state, and because of this, they think that such peptides are antigens. So, in pro-inflammatory state, organism begin to produce hypercitrullinated peptides. Macrophages uptake them by phagocytosis and present hypercitrullinated peptides on MHC2 receptors. And now, even if MHC2 receptor knows how to present citrullinated peptides, T helpers cannot recognize citrullinated peptides in hypercitrullinated state. So they think that this peptide is looking abnormal and thereby it's antigen. And in response to antigen, they becomes activated. So because T helpers cannot recognize citrullinated peptides in hypercitrullinated state, they send them as antigens, and in response to this, they immediately becomes activated. In case of HLA-DRB101 or 04 alleles, it's even more likely that inflammation will develop, simply because the receptor do not know how to present peptide, and peptide is in hypercitrullinated state, so it's looking differently. In all these cases, T helpers will be activated, and in activated state, T helper activate B lymphocytes that results in massive antibodies production, and also T helper activate T killers. So in response to antigen, T helper becomes activated. Once T helper becomes activated, T helper by JAK pathway and by production of interleukin-6 activate B lymphocytes. If B lymphocytes becomes activated, they begin to produce antibodies. First of all, they begin to produce antibodies against citrullinated peptide. We call them anticyclic citrullinated peptide antibodies. And also, B lymphocytes produce immunoglobulin M antibodies against the Fc portion of immunoglobulin G in our blood. So it's antibodies against antibodies. We call such antibody rheumatoid factor. Also, with activation, T helpers by production of interleukin-6 activate T killers. And activation of T killers create a direct threat to a cartilage in our joints. With activation, T killers infiltrate cartilage, where they cause inflammation that results in cartilage destruction. Anticyclic citrullinated peptide antibodies are quite reactive substances that in combination with tumor necrosis factor alpha can activate osteoclasts. With activation, osteoclasts begin to destroy extracellular matrix of the cartilage, and after cartilage, they begin to destroy bone tissue. Severe inflammation inside the joint begin to irritate synovial tissue that covers our joint cavity. And alterations in the synovium cause formation of a pannus, which is a signature feature of rheumatoid arthritis. So we have to understand what is pannus, how pannus is formed, and why it's so dangerous. Here we see an X-ray of knee joint. We have two bones, between bones we have cartilage, and our joints are surrounded by the synovium. Synovium consists of connective tissue and various cells, and there are two types of most important cells. It's fibroblastic synovial cells and macrophages. So the same structure has the second joint, bones, cartilage, and synovium. But if only severe inflammation inside the joint develops, macrophages very rapidly differentiate into the osteoclasts. Activated osteoclast inside the joint is a huge problem, because they secrete a lot of proteases that destroy bone tissue, and with time it creates bone erosions. But also, inflammation markedly increases the proliferation rate of fibroblastic synovial cells. And with increasing amount of synovial cells, the thickness of synovial layer increases. Basically, synovium even invades cartilage, and because inflamed synovium has a lot of osteoclasts, such invasion causes massive cartilage destruction, and with cartilage destruction, interjoint space decreases. In addition to this, with time, inflammation forces fibroblastic synovial cells to turn into myofibroblasts. The major difference is that unlike normal synovial cells, myofibroblasts have a huge contractility. So synovium not only becomes thicker, but also stiffer due to the contraction of myofibroblasts. And this creates so-called morning stiffness that lasts longer than 1 hour. Because joint becomes stiffer, joint mobility decreases, and also asymmetric increase in synovial layer in some cases can cause joint deviation. And exactly such thick, altered synovial membrane we call pannus. Now there is an X-ray of two knee joints in a patient with severe rheumatoid arthritis. What do we see here? First of all, there is very thick synovium, and inflamed synovium, as we know, composed of myofibroblasts and osteoclasts. Osteoclasts cause formation of erosions and areas of osteopenia. Super thick synovium decreases joint mobility, especially in the morning, and this causes so-called morning stiffness that lasts longer than 1 hour. Because such synovium has invaded cartilage, osteoclasts basically destroyed the entire cartilage mass, and here we practically do not see cartilage, simply because of synovial invasion of interjoint space. And excessively thick inflamed synovium we call pannus. On X-ray we can also see increase in soft tissue mass. Soft tissue here is synovium, because synovium is a connective tissue with cells. Also, because there is no cartilage, the space between the joints decrease, we call this decrease in interjoint space, and such thick synovial membrane we call pannus. Sometimes pannus can cause severe deformation of the joint. To illustrate this, here we see an X-ray of the hand, and around metacarpophalangeal joints we see excessively thick synovium. Such synovium we call pannus, and we see that the mass of the pannus on the left side substantially bigger than the pannus from the right side. We know that pannus is composed of myofibroblasts that have huge contractility, and they pushes bone to their side. So pannus from the right side pushes to the right, and pannus from the left side pushes to the left. And the larger the pannus, the higher the amount of myofibroblasts. So because from the left side we have more myofibroblasts, they pushes bone to the left side, and such deformation we call ulnar deviation. Another deformation we call Boutonierre deformity. This deformity occurs at distal interphalangeal joints. Here we see flexion in proximal interphalangeal joint and hyperextension in distal interphalangeal joint. This forms this angle in distal interphalangeal joint. In the thumb, we see so-called hitchhiker thumb deformity. It is similar how a person would normally angulate and hold out the thumb with the intention to hitchhike. Severe inflammation causes increase in white blood cells, increase in ESR, and increase in C-reactive protein. All of this we can determine by complete blood count and biochemical analysis. Destruction of cartilage and destruction of the bone tissue we can determine on X-ray. So because rheumatoid arthritis causes severe autoimmune inflammation, all inflammatory markers will be elevated, its white blood cells, its ESR, and its C-reactive protein. Also, because it's severe inflammation, there will be present general symptoms, as fever, fatigue, and weight loss. Also, chronic inflammation causes increase in hepcidin, and increase in hepcidin causes anemia of chronic disease. Clinically, one of the most important features is that rheumatoid arthritis affects multiple joints at once in a symmetric fashion. Moreover, rheumatoid arthritis likes small joints. Usually, it joins in the hand or feet, as proximal interphalangeal joints or metacarpophalangeal joints. But rheumatoid arthritis do not like distal interphalangeal joints. As a result, usually distal interphalangeal joints remains practically normal, while other joints become severely affected by the disease. So here we see an X-ray of hands. First of all, in proximal interphalangeal joints, the space between the bones is practically absent. We call this joint space narrowing. It tells us that the major portion of cartilage is destroyed. The same joint space narrowing we can also see in metacarpophalangeal joints. Also, in metacarpophalangeal joints, we see erosions of metacarpal heads. Bone erosions usually are caused by osteoclasts that destroy articular bone. Also, we can see erosions at carpometacarpal joints. At pancarpal areas, we also see multiple bone erosions in combination with joint space narrowing. There are practically no healthy-looking joints. All of them are to some extent affected. And also, at metacarpal joints, we see a darker areas of osteopenia. The darker the area, the less calcium is contained in the bones. And when osteoclasts washed out calcium from the bone tissue, the density of the bone decreases and thus osteopenia develops. At this point, just look how symmetric is the injury. So rheumatoid arthritis affects multiple joints at once in a remarkably symmetric fashion. But also interesting that distal interphalangeal joints are not affected on both hands. To remember this feature, just recall that osteoarthritis affects old people. So osteoarthritis occurs at a more distal periods in life, and thereby it affects distal interphalangeal joints. Rheumatoid arthritis occurs in young people in a more proximal period of life, and thereby rheumatoid arthritis affects more proximal joints. Because rheumatoid arthritis is autoimmune disorder, B lymphocytes begin to produce antibodies against normal proteins, and in the serum we can determine anti-citrullinated peptide antibodies and antibodies against immunoglobulin G, also known as rheumatoid factor, which is a signature feature of the disorder that greatly helps in diagnosis. And also we can determine genetic risk factors based on the presence of HLA-DRB1 01 or 04 alleles. For clinical medicine, rheumatologists summarize the most signature features of rheumatoid arthritis into the diagnostic criteria. The first criteria is joint involvement. Rheumatoid arthritis affects multiple joints at once, and rheumatoid arthritis likes small joints. So the more joints are affected and the higher the amount of affected small joints, the more likely it's rheumatoid arthritis. The second criteria is serological markers. It's rheumatoid factor and anti-citrullinated peptide antibodies. The higher the amount of antibodies against citrullinated peptide and the higher the amount of rheumatoid factor, the more likely it's rheumatoid arthritis. The third criteria is acute phase reactance. Rheumatoid arthritis causes severe inflammation that results in increase in C-reactive protein and ESR. So the higher the C-reactive protein and ESR, the more likely it's rheumatoid arthritis. And the fourth criteria is duration of symptoms. Rheumatoid arthritis is a chronic disorder, and as in any chronic disorder, symptoms last for a prolonged period of time. In this case, criteria is more than 6 weeks. Such a severe autoimmune inflammation affects not only the joint, but also it causes alterations in different organs and systems throughout the body. The most important one is formation of rheumatoid nodules. Here we see multiple rheumatoid nodules that can be very prominent on examination. Histologically, rheumatoid nodules are just fibrinoid necrosis combined with histiocytes, and as we see rheumatoid nodules located subcutaneously. The combination of rheumatoid arthritis with pneumoconiosis and rheumatoid nodules we call Caplan syndrome, and the combination of rheumatoid arthritis with splenomegaly and neutropenia we call Felty syndrome. Nowadays, we have a lot of medications for rheumatoid arthritis. They can be subdivided on 2 groups. The first group are traditional disease-modifying anti-rheumatic agents. It's a pioneers in treatment of rheumatoid arthritis. The major feature is that it's non-selective drugs that have systemic effect and thereby a lot of side effects. Among them, methotrexate is by far the most popular drug. With time, we developed a whole new group of agents for rheumatoid arthritis. We call them biologic disease-modifying anti-rheumatic agents. The major benefit is that they selectively target a specific link in pathogenesis of rheumatoid arthritis. The first class of drugs called T-cells inhibitors, it's abatacept. We also call them co-stimulator inhibitors. Co-stimulation inhibitors, as abatacept, inhibit activation of T helpers. Without activation of T helpers, activation of B lymphocytes becomes impossible. As a result, the production of antibodies decrease and activation of osteoclast becomes impossible. So as a result, we decrease destruction of cartilage and bones. And also, activation of T killers becomes impossible. And by this we decrease the severity of inflammation and prevent cartilage destruction. The second class, called interleukin-6 inhibitors, it's tocilizumab. Interleukin-6 inhibitors inhibit interleukin-6. Without interleukin-6, we cannot activate B lymphocytes, and thereby the production of autoantibodies decrease and osteoclast activation decrease. And also, without interleukin-6, we cannot activate T killers, so cartilage infiltration decrease. So by this we again prevent cartilage and bones destruction. The third class, called JAK inhibitors, it's tofacitinib. JAK inhibitors block JAK pathway. Without JAK pathway, T helpers cannot activate B lymphocytes. By this we decrease the production of autoantibodies, and also we decrease activation of osteoclasts. As a result, we prevent cartilage and bone destruction. The fourth class, called B-cell inhibitors, or we call them anti-CD20 antibodies, it's rituximab. Rituximab causes apoptosis of B lymphocytes. With decrease in B lymphocytes, the production of autoantibodies decrease, and thereby osteoclast activation decrease. By this we prevent destruction of cartilage and bone tissue. The fifth class, called TNF inhibitors, it's infliximab. Infliximab blocks tumor necrosis factor alpha. Without TNF, osteoclast activation decrease, and thereby cartilage and bone tissue destruction decrease. Also we have interleukin-1 inhibitors, but the problem is that it's the less effective drugs among all of them. Also, to prevent rheumatoid arthritis, we should recommend to avoid risk factors, as smoking, because without provoking the disease, rheumatoid arthritis can remain basically silent. So to summarize, first of all, we have to recommend avoidance of risk factors. From the drugs, we have co-stimulator inhibitors, interleukin-6 inhibitors, JAK inhibitors, rituximab, and tumor necrosis factor alpha inhibitors.